attending today's webinar. I hope everybody's ready for just a few minutes of thinking and discussing. First, I want to introduce myself. My name is Amanda Kinsler, and I am one of the instructors at the Patient Safety Leadership Master's Program. And I really appreciate your time today. I also wanted to say just a little bit more about myself. I also am a risk management specialist at the University of Texas Medical Branch in Galveston, Texas, and I've worked here for several years. I've been a nurse for 24 years and a risk manager for 12 years. And I received my master's at Lund University in Lund, Sweden, on human factors and system safety. And part of the project of that master's degree was to do a thesis. And so I thought I would share a little bit about this thesis with you today on error in healthcare incident reporting among nurses. Do we need to rethink our approach? So this is kind of what I wanted to look at was, you know, how the healthcare system's approach to human error can really possibly guide nurses' view of human error and influence incident reporting in a hospital setting. The objectives today are to identify nursing organizational documents and state laws that influence reporting or not reporting, and explore nurses' perception of human error as it relates to incident reporting, to identify why nurses report events and barriers associated with event reporting, and identify the implications for future knowledge of the value of understanding human error within the healthcare system. For over a decade, the healthcare industry has really attempted to mimic the non-medical industry with the use of incident reporting as one of the many tools used to increase patient safety. But often healthcare workers are trained to perfect individual performance, and human error is actually viewed as a personal failure instead of a natural course of systemic contribution. This qualitative case study explores how the healthcare system's approach to human error can influence the nurse's perception of human error and how this influence is manifested in the incident reporting culture. Also encompassed in this study is the nurse manager's view of human error as they manage the nurses who self-report and report on their peers. Lastly, the just culture concept is really discussed as it intertwines with the complexity of incident reporting. Two approaches to human error from safety science literature, the old view versus the new view, were used as a conceptual framework to portray the possible differences the two approaches institute themselves in the nurse's understanding of human error. Key organizational nursing documents and state laws were analyzed to examine the healthcare system's approach to human error and incident reporting and their influence on nurses' perception of human error. The research problems were, how do nursing organizations view human error? What do we think about human error? What drives a nurse to write an incident report or not? And how do nurse managers react to human error or incident reporting? In the literature review, I started with the safety science framework review of the old view versus the new view. Just in short, the old view approach believes that erratic people degrade an otherwise safe system and complex systems are basically safe, that humans are unreliable and undermine defenses and only follow rules and regulations. And to make the system safe again, restrictions on the humans needs to be tighter. The old view explains that this approach really is based on outcome of an event and oversimplifies a story to find basically a single cause of a mishap. The new view approach believes that people create safety actually at all levels of a system by learning and adapting to information about how we can all contribute to its success and its failure. Human error is not the cause of failure, but actually a symptom of deeper trouble. And it is not random, but it is connected to the features of people's tools and operating environment. The studies on medication incident reporting around the globe really gave light to the complexity of multiple barriers nurses have to overcome in order to report an error. It gives awareness that self-preservation, fear of peer rejection, and manager reprimand has a great impact on the decision to report an error. Consequently, how the nurses view human error has a large impact of what is being reported and why. In 1995, a British study stated that in the hospital setting, there are many individuals along the path of medication delivery and administration, but often it is the nurse who is held accountable for errors and its consequences. The fear of guilt, the effect on patients, the loss of confidence in their clinical ability were often factors to not report. And this was replicated in an Australian study with similar results, finding self-preservation caused underreporting, and nurses relied really on life-threatening events to indicate whether they would report or not. In 2010, a Taiwanese study noted that nurses' attitude and judgments toward reporting of self and their co-workers were major detriments. And lastly, a Greek study in 2010 also discussed the ways that nurses coped with error, found a high percentage of nurses' emotional response of depression, anger with themselves, feeling of inadequacy, and embarrassment, and the patient's clinical responses were a struggle when an error happened. This Greek study and a U.S. study revealed that if the nurse manager's handling of an error gave a more supportive role, the nurse was more empowered for a positive change in their work and in their lives. Looking at the methods, the sampling collection came from a U.S. major academic hospital that employed over 10,000 employees and included more than 40 hospital inpatient care areas. The sampling data was gathered from interviews and compared to documents published by various healthcare organizations and nursing state laws. 3 nurse managers and 5 inpatient acute care nurse participants were chosen in this research study to understand nurses' experience, value, and opinion related to human error and incident reporting. To find my example, I identified 3 hospital units with a high rate of incident reporting and 3 units of low rates of incident reporting to select 3 nurse managers from those 6 units. After identifying these 6 nurse managers, I asked for participation in the study. The first 3 managers on the list of the 6 agreed to participate. After each nurse manager had completed the interview, I asked for 2 or 3 names of nurses who might participate in the study. Each nurse manager gave me at least 2 names for me to choose. Out of those names, I randomly selected 5 nurses to participate, and everyone selected did participate. The inclusion criteria, the nurse managers were from an inpatient care hospital unit, and the nurse managers had more than or equal to 4 years experience as a manager, and all 3 managers actually had Bachelor's of Science of Nursing and 2 had master's degrees. And the registered nurses were from the same hospital care units as the nurse managers and had more than or equal to 1 year experience. All of the participants had their bachelor's degrees. And this actually gave us enough data for what was essentially a pilot study of an extremely complex problem. I did use 10 semi-structured, open-ended questions in this study, and the interviews consisted of an average of 60 minutes. The questions were divided into 2 topics, 5 on human error-related questions and how nurses and nurse managers defined human error. And the second 5 questions discuss the term incident reporting and how each nurse or nurse manager viewed incident reporting and its usages. So approval was obtained from the participating University Institutional Research Board, and confidentiality was maintained by assigning numerical codes and unique pseudonyms to each participant. And the document analysis was used to study healthcare organizational views and laws related to human error and incident reporting. The documents chosen are listed on this slide. As you can see, American Nurses Association, it was the 2001 version, a code of ethics for nurses with interpretive statements. And I will say that in the edited changes from 2014 are actually the same wording. And in American Nursing Association position statement on just culture, the Agency for Healthcare Research and Quality, Chapter 4 on incident reporting, and Texas Occupational Code, Title 22, Part 11, Chapter 217, and the Texas Board of Nursing Position Statement 15.17 is the Texas Board of Nursing and a Board of Pharmacy joint position statement on medication error. And I'm just going to give you some highlights that I thought were interesting from the document analysis. And through a document analysis, I saw there were several key nursing laws and influential organizational bodies which influence our thinking on human error in nurses. These were chosen to review. Remember the concept or the conceptual framework that I talked about before, the old view versus the new view. Kind of see if you can pick up on what might be considered an old view or new view concepts as we go moving forward in the results and discussion. First, let's talk about the Texas Occupational Code, and this is just a highlight of some of the information found in these documents. Title 22, Part 11, Chapter 217 does state that it requires a manager to report a nurse to peer review if an error contributed to the death or serious harm of a patient. Or the manager is required to report a nurse if a nurse had 5 minor errors in a 12-month period of time. And as you know, that this is very subjective to what the manager would believe would be a minor error. So the ANA Code of Ethics in 2001, and like I said, it didn't change in 2014's new edition, the nurses are accountable for judgments made irrespective of organizational policies or provider directives. The ANA Just Culture position statement states that a just culture recognizes that an individual practitioner should not be held accountable for system failings. And the Texas Board of Nursing joint statement with the Board of Pharmacy states that medication errors are a multifaceted problem which may occur in any healthcare setting, and acknowledgement the interdisciplinary nature of medication errors and how often poor system design can create failure. And looking at the interview data, as a result of the 10 questions asked, several themes emerged. How the nurses define the human error, nurses' perception of how their organization approached human error, and how was incident reporting utilized or why nurses report, barriers associated with nursing incident reporting, and nurse managers' barriers in incident reporting. As we looked at the nurse's definition of human error, three things became apparent. A nurse being basically substandard or a personal type of attribution was accredited to the definition of human error by statements that brought in concepts of actual inadequacy, competency, and responsibility. When asked for their definition of human error, the participants stated their definition as human error was misguidance, a lack of judgment, a lack of education, a lack of proper training, not meticulous enough, and a lot of laziness. Human error is a mistake whereby prudence was not practiced or observed that led to commit a breach of public safety. Human error is committed by staff arising from behavior or deviations from protocol or standards of care. These statements kind of appear to be considered a basic old view approach, either premeditated or that a nurse would want to cause harm to some extent, and the nurse needed to improve. Only one statement appeared to find a new view approach by the nurse participant stated, someone who makes a mistake unknowingly or unintentionally thinking it was the right thing to do at the time because at the moment it was done, they thought it was the right thing to do. The last statement actually reveals kind of a normalcy of the daily routine that can actually lead to an error that's made. The nurse participants were asked also their perception of how their organization viewed human error. This actually appeared to be very dependent on how their nurse manager handled error at the unit level. Severity bias was a subtopic by many statements made that the error is handled differently depending on the severity of the event. If it was minor, it might be overlooked. If no one is harmed, if it were mild or moderate error, you would be talked to by your manager, then written up and counseled. You could get probation and then be terminated if it was a severe event. The second subtopic basically talked about an illusion of control. The participants believed that an organization could perfect all their systems so flawlessly that no error would happen. It's always best to deal with an issue before it happens, that a manager can make the system flawless and no error would occur. They also noted and attributed their organizational view actually to bad apples and scapegoating by statements such as, nurses are just lazy, you have to stay on their butts. Some individuals do things that they know that are not right. They choose to do blatant errors, it's their behavior. The nurse participants actually described this bad apple concept, believing that if the behavior were better, the system would be safer. These bad apples are actually the primary focus instead of looking into the systemic flaws, which can be workload, staffing, high acuity, burnout, time constraints, tools like the electronic medical record interface, and various equipment and environmental issues. Why nurses report events? They reported events basically, like I stated before, if it was high severity. Usually it is the severity of the event. That's why I've decided that I would write an incident report. If it's a sentinel event, I'll write an incident report. Often by categorizing an adverse event into the severity classes, it often gives a false sense of accountability placed on the reporter of a severe event as opposed to a reporter of a near-miss event or a minor event. They often can get praised for putting a near-miss event in. So whether severe, minor, or near-miss events occur, the same review of the systemic weaknesses could occur, but often do not. The system of incident reporting should not always be based on the effects of the patient, but the potential of unsafe conditions that are often repeatable within the systemic process. Tattling was also an attribution to why nurses reported by statements such as, people place incident reports on me, so I'm going to put them on them. Instead of helping me, they place an incident report on me. Due to the fear of being the target of blame, a person will often point the finger at another individual or often another department. Thirdly, with statements such as self-preservation were strong statements too. If you're not the one that gets to the manager first, then the blame goes on you. Stories are twisted, and that the nurse and the physician, whatever they say, that's what is dependent on how the incident is presented to the manager. And it's noted there on the slide that 3 out of 5 nurses say they would rather report a peer than themselves, stating that it's easier to look at another individual than themselves. Some of the associated barriers, although much of healthcare organizational literature promotes a less blame approach and more of a just culture approach, it seems yet to infiltrate the ranks of these participants. The same barriers existed in the nursing literature as fear of punishment, fear of peer confidence, manager reaction, and trust. The incident reporting system appeared to be used to communicate actual faulty behavior or tattling on themselves or others within the system, and very little to do with the system. Instead of teamwork, trusting each other, and looking at the systemic vulnerabilities. A culture cannot be a just culture as long as the system is very unclear on the normal fallacies of human behavior within the work environment. Secondly, having a just culture actually takes in all views of the story, and it protects those involved and proportions accountability fairly. The nurse managers noted that stories did often get twisted up, and they focused on an individual in the story, and the description in the incident report was very subjective, and that would be why the incident report was written, is to focus on the individual in the story. They also noted mistrust and suspicion among the nurses toward management were key factors and created challenges for the nurse managers because of the lack of trust and suspicion. The nurse manager also appeared to want to protect some of the staff. One nurse manager really felt like she was afraid for them to put the incident report into the incident reporting software because then administration would know. And so she really didn't trust the system. The fourth barrier was the confusion. I think it's kind of interesting, is the confusion of nursing ethos and mistakes made. One of the participants stated, having a good relationship and rapport with my manager has made all the difference in my reporting. Well, that statement in and of itself is really a good statement, but then she kind of moved on and said, I think she thinks I'm a good nurse and I don't make mistakes all the time. The strong emphasis on moral character and nursing judgments in nursing organizational position statements may overpower the systemic complexities within the healthcare delivery of safe patient care. This view of human error makes one believe that human performance is substandard and flawed when viewed in hindsight and led directly to a negative outcome. This really old view approach kind of retards any advances in our understanding of how healthcare complex systems can fail, and the roles practitioners play can be both successful and unsuccessful in the operations of the healthcare system. This study really contributes to the nursing literature as kind of an exploration of the way that the healthcare system approaches human error and how it impacts incident reporting in the healthcare system. The narrative may focus on characteristics of individuals by the reporters' understanding of their definition of human error. And healthcare organizational documents and laws portray both old and new views. The broader system definition of just culture may not really be enough to move the tipping point to look at a systemic approach. Elements of the old view approach, such as severity bias, bad apples, scapegoating, tattling, illusions of control, were revealed by these participants. Overall, the internal and personal definition of what a nurse believes is human error validates what is reported to the nurse manager or placed into the incident reporting tool. Since the healthcare system actually is in its adolescent years of initiating and publishing safety initiatives the last 20 years, change really may evolve over time to assist nurses to understand the complexity of our systems we work within in our normal everyday work life. This ownership will increase accountability to improve the systemic vulnerabilities and less focus on the individuals within the system. The implications are the local level recommendations for all nursing leadership and nurses to improve the understanding that our standards and ethos really are not related to accidents. We should look beyond the reporter. We cannot actually reach a point of perfection, and nurses should continue to study the normal everyday work processes to look for system improvements. And organizational documents and state laws should balance system weaknesses within healthcare organizations against errors made. And for nurse managers really to evaluate their own reaction to incident reporting and to support the understanding that error is based on a variety of factors within the complex system. Limitations in future research, really limitations is, this was really a small study, one hospital, and the future of the research could broaden to study or to do repeat this process in other hospitals and other maybe nurses or other professions. And the next line of inquiry could be that to focus on understanding the nurse's pressures of perfection and understanding human factors within healthcare. And these are just some of the cited literature that I have that go with the lecture. And I will, I guess, at this point, turn it back over to Sean. I think Sean wants to talk a little bit about the online patient safety leadership program.
Yeah, well, thanks everybody, and thank you, Amanda, for the presentation. Very informative. And as Amanda had mentioned in the beginning, she is a professor and an instructor in the program. And you can correct me if I'm wrong. You typically are teaching the PSL 502 course. Is that correct, Amanda?
Well, I actually currently working with the 501 course.
501. Okay.
Well, I kind of move around. I've been since I've worked a little bit with, I've worked with the 401 course, and I've worked with the 402 course on error science, and also with the I believe the 501 courses, the health information and technology
portion. Mm-hmm.
portion. So I've gotten to
done a few.
Quite a few of them. Yeah, yeah.
Yep. No. So I wanted to make sure I give you the right credit there for all the different ones that you've done.
Okay.
But yeah, so we're using all the different names of the courses there. But yes, essentially, that's what I wanted to show everybody is, I know a lot of people that are on here are also looking into these programs. These are sort of the two options that you have in terms of taking the program. So there is a full master's program, which is 9 courses that you complete. There is a 3-day residency, and that is what the course that we're talking about, PSL 501, Healthcare Simulation Team and Applied Leadership Principles. That happens, it's an 8-week course, but you're doing a 3-day residency here in Chicago. So that happens about halfway through, and there's the total to complete the program's 9 courses and can be done in about 20 months. If you're not sure, I know for a lot of the students that are looking into the program, they're not typically sure if they want to complete a full master's program. So sometimes they'll think about stepping into the certificate program, which is really the first 3 courses of the master's program, which can be done completely online. So it's 3 8-week courses. But then if you are choosing to move on for the master's program, then those courses fold into the full master's programs. And just a couple more slides that we wanted to show everyone that's on today for the presentation before we open it up for kind of general Q&A. This is just talking a little bit more about the capstone projects, which is what really, if you're doing the full master's program, what you're leading towards is completing a capstone project. And this can be a literature review. It can be a project that you're wanting to put in place at your place of work. So this just sort of gives you an example of the scope, really, of all of the different types of projects that have been completed over the last 10 years that the program has been around, if not more. And then finally, we did just want to show quickly, just in terms of the people that are coming to the program, it definitely spans all of the different healthcare professions and really a number of different disciplines within all the healthcare professions. We do have a lot of people looking to kind of move up into a patient safety role, but for the vast majority of the students that come to us, it's people who already have the role and they're saying, I now need the education sort of in the role. So this just sort of gives you an example, and there are now over 100, I think there's over 120 graduates of the program since we've been in existence. But yeah, at this point, we'll go ahead and if you have any questions either about the program or to Amanda about the presentation, then feel free to type those in. I'll read those out loud, and then we can go from there. But it looks like we actually already have some, Amanda. So I'll read that out. The data you presented about the influence that a nurse manager's attitude has on nurses' organizational view of human error it seems to be fascinating. How might an organization, either at the micro system or the macro system level, influence this phenomena?
Oh, wow. That's an interesting question. I really appreciate that question because it's actually so deep. I think that's one of the struggles that we have in our training as nurses and physicians. A lot of the training is deep-seated from the very beginning as you're a young nurse or a young physician, and then you move into this organizational world, and your views often are hard to change, and it's hard to change what people think, and our society as a whole has their own view of human error and causes of accidents. It doesn't matter if you can watch the news at any single moment and find that they're going to blame somebody for some huge problem and, chop their heads off or fire them because of some huge problem. So how do you change that line of thinking when it's part of our culture? And I think it takes a lot of thinking, collaborating with other like-minded people that really want to look deeper into and I think anybody can do this, and even in the program here at Patient Safety Leadership Masters program, you know, a lot of the courses look into these questions, and a lot of it has to come from inside of you and how you believe you want to, you know, work on a event that happened. What are the causal problems in the environment that could create this environment that an error was made? And it's really hard for all of us to back up and to not want to blame an individual, because that's almost a natural response, and you have to step back and observe and think of all the things that could create any one of us in that situation. It could have happened to one of us. And so I think it takes a lot of deep thinking. I think you can get a group of people together that are like-minded, that want to think more on the new view, and read some of, you know, the field guide. Sydney Decker's field guide is a great, simple book to read, but I think everybody uses it kind of, it's like the Bible of safety too. You know, it's just really general, and I think that would be beneficial if you wanted to get that book. We use that book as a text in the Patient Safety Leadership Masters program, and I think it would really help.
No, thank you. And great question there as well.
Yeah, well, it really was. I appreciated that question.
Yeah. Other questions? I know we did kind of schedule half an hour, so I know I already had seen some. I know we're a little bit over on that already, but if anybody has other questions, feel free to type them now.
Yeah.
This is, Amanda, this is usually when I do my silent count of 1, 2, 3, right, if nothing comes up here.
Okay. Yeah.
Other questions? Give it one more minute here.
Well, I hope I answered their question. That's really a deep, hard question to answer, you know. Yeah. And but I appreciate the question.
No, very, very, very thorough answer as well.
Oh, thank you.
All right. Well, I'm not seeing anyone else typing at this point, so we'll go ahead and kind of just thank everybody for attending. We will be sending you a recording of the presentation. Feel free to share that with others. And then, as always, if you have questions about the program or want to relay any questions that you have for Amanda, go ahead and you can either email us at the onlineinfo@uic.edu or or call us at the 866-772-2268. Number as well. But thanks everybody for joining us, and Amanda, thank you so much for the presentation. It was great.
Okay, thank you so much.
All right. Thanks everyone. Have a good day.